So this patient presented with a history of holocranial headache, and he was treated in a local hospital, and then after 1 month he had an imbalance while walking with swaying to side, for which he was evaluated and treated. So this was going on in some private hospital, which was, and the exact details of all those were available. So whatever available, I will share with you. So then he was again treated, but again after 2 more months the illness, he started having behavioral abnormalities like forgetfulness, navigation difficulties at home, visual hallucinations, and aggressiveness in his behavior, right? So he was becoming little aggressive. And also he had one episode of generalized tonic-clonic movements. So whatever uh, he has a personal history of he was a smoker. So 1 or 2 BD bundles per day for last 50 years. So quite a significant history of smoking for long years, and he was also known for alcohol intake for last 50 years, right? And there was a significant family history also, like father had a history of leukemia, mother had history of diabetes, right? And their other family members had diabetes and one had CLD. However, none in the family had this kind of a complaint of headache and swelling and behavioral changes in the family. So if we go back to the history, one holocranial headache, imbalance in walking, and not able to walk in a straight line, and then some behavioral abnormalities, and one episode of seizure, right? So what could be your clinical possibilities with such a thing? So anyone wants to volunteer?
Sir, any neurological illness can be there.
Yeah. It must be neurological illness, because you can see headache, abnormality in behavior, movement, seizure. So it all points towards a neurological abnormality. But what type? Do you think this could be a tumor? You think this could be a infection? You think this could be some developmental abnormalities, or it could be some inflammatory disorders, demyelination? Any idea?
So any infection can cause holocranial headache.
Yes. So one that is important aspect, headache. So when there is a history of headache, the first thing that comes in our mind is there is raised intracranial tension, right? So
TSM.
it can be infection, it can be something else. But what kind of infection you think? This is a brain abscess, you think this could be a meningitis? What could give you more this kind of an holocranial headache?
So meningitis,
Meningitis. So
Diffuse.
when there is too much of
bacteria.
holocranial headache, this actually we can't pinpoint too much just based on this history. It can be quite broad unless I give you other investigations, the radiology and other things. So that is difficult. So most important here, because you have a history of increased intracranial pressure with headache, some abnormalities. So two important investigations that must be done at this moment. So can someone tell what are the investigations of choice?
NCCT head.
CT.
CT.
CT. CT scan.
So yeah, CT scan is good thing, but when patient is there for quite long time, and there's no acute emergency, so better to go for MRI, a contrast enhancing MRI. CT can also be done. I don't say it is not a good investigation, but if you want to have a detailed morphological evaluation, it's better to get one MRI done. Okay, one is imaging. Number two,
CSF
CSF
examination.
analysis.
CSF
CSF analysis,
examination.
exactly. So that will give us some important clues, because this kind of a holocranial headache and all can also be seen in other neurological even in malignancies, especially if there's a meningeal carcinomatosis or a lymphomatosis, something like that. So that they can also have this kind of a presentation. So okay, let's see. Okay, so he had some investigations done. So he was also found to be had a shock and Mobus type 2 block, and so and he underwent other investigations. So radiology. So this was the first radiology. If we see here, the flare. So grossly, if you don't see, if you see overall, there is not much change, right? You can see these cortical ribbons, the signal intensity, the CSF is black, so this is flare. You know, it's important if you want to practice neuropathology, it's very important that you should have some basic knowledge about the radiology, because sometimes as a pathologist, when you see a slide and you find something very particular, and if you want to correlate with the radiology, it's better that you should be able to see your films yourself, how to evaluate them. Okay, so grossly there was not much finding during that time. Okay, you can see this. This is the cerebellum, right? These are the lateral ventricles, this is the periventricular region. There are occasional mild, this kind of altered signal intensity. You can see small, but these are not very specific. These are bilateral. So this could be because of some cerebral microvascular disease, which cannot explain this kind of a presentation, right? Again, and diffusion weighted image, there is no diffusion restriction or something except occasional foci you can see here, but again this is very minute and bilateral, not particularly pertinently to some particular vascular territory. So so not much changes based on the radiology. So as you all mentioned, further what is the next investigation you should do?
CSF examination.
CSF examination. So this is the CSF analysis, right? So sugar is low, protein is high, and there is a lymphocytic pleocytosis. So exact values we didn't have because it was performed somewhere outside, right? India preparation was done, which was positive for Cryptococcus. So other routine hematological and biochemical investigations were within normal limit, and patient was also evaluated because patient is a you got Cryptococcus in CSF, so obviously everyone will think that it can be a immunocompromised patient, right? This is more like an opportunistic infection. So HIV and other investigations for immunocompromised state was performed, but they did not find anything very significant. HIV was also negative, right? So do you think these CSF parameters, low sugar, high protein, lymphocytic pleocytosis, can they go with this cryptococcal infection of CNS, or this is against it?
Can go.
They can go, right? So so in TB, in viral, where all you can see this kind of a presentation, but in usually in viral, sugar is not very low because it is you know why the sugar is low in CSF in infections, especially
Bacteria
biogenic. Yeah,
bacteria consume glucose and replicate.
it's not bacteria. It
In
is,
bacterial meningitis.
yeah. So what consumes the glucose? It's the neutrophils, right? So it's a
Neutrophil.
highly inflamed state where there are a lot of inflammatory cells, especially neutrophils, which consume the glucose, right? So, but it can also occur with other infections. Okay. So you are diagnosed with cryptococcal meningitis, started on amphotericin B, right, which is an antifungal drug, but no, not much improvement. He developed facial deviation to right side and difficulty in closing left eye. What does it mean? Facial deviation to right
Stroke.
side and difficulty in closing left eye.
Stroke.
Lower motor neuron
Stroke.
taxing.
What type of neuron?
Lower motor,
What is lower motor neuron?
like
So this is cranial nerve, right? So it's facial involvement. Yeah, facial nerve involvement. Now someone has written facial nerve involvement. Which side is facial nerve involvement? Am I asking too many questions? Yeah, facial nerve, correct. Which side? Left or right?
right.
Thing is going great. Deva, you must ask questions. They'll think at least, Please. I'm enjoying it.
Thanks, sir. So this is left-sided facial
Left
nerve
side.
palsy,
Left side.
right? So in left, it is in cranial nerves, it's the same side. In spinal, it is the opposite side that is involved, right? So there's a gross motor thing. Okay. There's still headache going on and off. Again, outside evaluated with MRI, interval MRI, and the antifungal was continued. So this was the MRI after 2 months almost. Now, any changes? If you compare with the previous, I think there's some changes. So if you look at these ventricles, what is happening to these ventricles? They are slightly dilated, right? You can see these angles of the ventricles are kind of rounded up now. So there is some hydrocephalus this patient is developing compared to the previous scan. Second thing, if you see carefully, so this is anterior, this is posterior, you can see these orbits, right? So this is which lobe of the brain? Can someone volunteer? This is anterior, this is posterior. So towards the posterior aspect, which lobe exists in brain?
Occipital.
Occipital lobe. Fantastic, occipital lobe. So there is some altered signal intensity in the occipital cortex. Can you make out here? This is almost like a half of a ring. This is not a full ring, kind of a half ring. You know?
Ring
Yes, sir.
enhancing region.
Yeah. So some ring enhancement here. This is not a cortical ribbon. So there is some difference if you see here from the color of the cortical ribbons. And here in the paramedian region of the occipital cortex, the intensity of this, especially if you see here, the intensity of the cortex is different. Right. So what does it mean? What is happening here? Any idea? Let me see if I have some more radiology. Yeah. So diffusion restriction, you can see. See, these areas are white. So diffusion is restricted here. So the diffusion material that is given is not reaching here. So there is a restriction. What does it mean?
Abscess.
Only 1 or 2 persons are answering. It's not exam. Yes.
Abscess or a tuberculoma.
Okay, one can be tuberculoma or some specific lesion. So if you see bilateral lesion like this, the other possibility would be some vascular abnormality, because there is some the whatever contrast we give goes via with blood, right? So if there is some obstruction of the blood flow to that particular area, then the contrast cannot reach, right? So then it causes the diffusion restriction. It's a contrast image. So it means there is some infarct, right? Which is devoid of vascular territory. Now what is MRA?
Angiography.
Right.
Magnetic
MR
resonance.
angiography. So why it was done? Because there was diffusion restriction, right? So it did not reveal any
Yes, sir.
significant vascular changes. So this is, so again after 1 month, so this is after 3 months of the illness, this MRI was done. So what are you seeing here? You see it was the occipital cortex, right? it becomes completely white. Right? So this is a bilateral occipital cortex involvement. Right? Suppose I tell you there is only one-sided occipital cortex involvement. What do you think should be the cause? Here we are getting both sided, so it has a different connotation. Acha, leave this occipital cortex. This is your basal ganglia region. You see, this is the internal capsule here, na? This is the thalamus. This is little posteriorly. Okay, so if you see here, suppose you see a diffusion restriction here or altered signal intensity here, which might be correlating with a infarct, one-sided basal ganglia infarct. What do you think? What could be the cause of this basal ganglia region infarct in an elderly male?
Hypertension,
Hypertension, stroke, right?
hemorrhage, yeah,
Atherosclerotic, which is a commonest cause, is
contaminal.
atherosclerotic stroke. So hypertension per se does not cause infarcts. है ना? If you are
Increased.
talking about hypertension and you are talking about a focal neurological deficit or a stroke, the first cause is intracerebral bleed, hematoma, right? Not infarct. I'm specifically talking about infarcts here. So then you think of middle cerebral artery territory infarct. The neural path outside your tumors is very vast, let me tell you. If you go to neuro-oncology practice, that's fine. You have some tumors, some markers, that's fine. But if you want to practice non-neoplastic neuropath, you have to be thorough with your neuroanatomy and the vascular supply and everything. And so, can someone guess if by this cerebral, this part of the uh, occipital cortex is supplied by which artery? I am not asking this particular name, but grossly which artery? If I am saying anterior cerebral artery, middle cerebral artery,
Posterior
yeah, that is the catch. It is not posterior cerebral artery here. It is part of anterior cerebral artery. So after this class, you will go and read the vascular supply of brain once again. In any paramedian region, anterior to posterior, it is only and only anterior cerebral artery. Only. So that means this bilaterally there is some vascular obstruction. So now, are there two different diseases in this case, or you think this is the same disease? So does the patient have both cryptococcal meningitis and elderly male, you see, presented with altered sensorium and all these things. And and this, if you see, can you see there is a sulcus here where my arrow is pointing? This is called, any idea? This is called calcarine sulcus.
Alkaline.
Right. And this cortex which is adjacent to it is known as, any idea? So that is the visual
Visual
cortex.
cortex.
Visual cortex, right? Or the striate cortex. So this patient had altered vision, right? I showed in the second slide after 2 months he had visual disturbances. So can you explain this with this radiology? Right. So there is visual cortex and bilaterally is gone. Right. So single disease or two diseases? Two? Okay. Right. So the clinician also had the dilemma whether the patient has single disease or two different diseases. Right. Again, you see diffusion restriction, this has become completely white. Right. So you can see bilateral occipital cortex infarcts here. Along with there is hydrocephalus. Again, MRI, I am now going go little fast. Again, bilateral occipital cortex, you can see diffusion restriction and this kind of altered signal intensity. There is some hydrocephalus, and rest of it was still going the similar way, right? So again, this is right, again same you can see here, right? So after 4 months, now this was going on, this imaging and all. So after 4 months, patient comes again. They have worsening of headache associated with visual blooding and vision and also altered sensorium, right? Now you can see this visual disturbances there. Develop stiffness in all arms and legs. Then no daily activities was possible. Now patient was given one IV methylprednisolone 1 gram, but not much improvement, and he was shifted to, now he came to our hospital, which was almost 4 months into his illness. So for last 4 months, patient has been receiving almost continuously antifungal, which was not much giving much relief. It was some intermittent remission, but again he was coming back. So after 5 months, this was the MRI. Now it has really progressed. Now, in addition to your bilateral occipital cortex, in cerebellum also you can see there are altered signal intensity. Again, these are because of infarcts, small infarcts, right? You can see here again bilateral occipital cortex, there are infarcts. This is your cerebellum, this is your medulla, so this is the posterior part where also there are some altered signal intensity. So multiple areas in the brainstem, in occipital cortex, bilateral, lot of vascular damage are going on, and some areas it is looking almost like, you see those rings, can you see rings? So now again, these are the CSF analysis. Cells are elevated, mostly lymphocytes. Low sugar protein, in one occasion it was high, other one it was not so much. Cryptococcal antigen is positive, right? On both occasions. Fungal smear, which was previously positive, Indian preparation, this time it is negative. Cryptococcal culture is also negative, right? Malignant cytology negative. Gene expert negative, AFB negative, AFB culture negative, parasite negative. Now what is happening? Okay, so other investigations. So in PET was done, so there was some leptomeningeal thickening, and as I said, bilateral occipital lobe in the same region it was thickened, and there is also a right upper lobe lung mass kind of a thing. It is bulky adrenal glands. And there was a skin lesion which was biopsied and it was reported seborrheic keratosis, and PET guided biopsy was done from right lung nodule. Now, with the development, anything else comes into your mind? Patient has brain lesions, patient now has lung lesion with quite good SUV max uptake. You see 10.
And
Ma'am,
it has spread to hematogenous spread of cryptococcus. It
Okay,
might
very
have spread
nice.
to adrenals or lungs as well.
Right. Anything else?
So lung
So
metastasis.
metastatic lesions.
yeah, you must think of a metastatic disease, because whatever we have seen so far is just based on our CSF picture and MRI. There is not tissue-based diagnosis, and malignancy itself is a immunocompromised state, right? So it is not impossible that there is some malignancy in the lung and it has metastasized to the meninges. I'll tell you, just two weeks back, I did an autopsy Patient had history of very short history of season and all, and MRI did not reveal much, so patient quickly died actually. And we did an autopsy. Grossly, the brain was not showing much, but when we saw the sections, the meninges were studded with malignancy. So it was a this was TTF positive. So this was a metastasis from lung. So when there is a meningeal carcinomatosis or meningeal lymphomatosis, it may not show much radiological things, and these cells usually are not shed in CSF so that you can see in CSF. Anyway, so our clinicians also thought in the same line and did a PET guided biopsy from the right lung nodule, right, which I will show later. What did it show? However, the patient, your induction therapy for lymphosomal lymphocytosis B was again given with flucytosine because this is not controlled, so they added flucytosine. Now, after adding flucytosine, they improved, right? And patient was discharged. And he was given a continuation on flucytosine and fluconazole 400 milligrams. So, antifungal patient was discharged. But after 1 month, he came back with worsening of headache, increased stiffness, with decreased movements of arms, fluctuation of his sensorium, and this time he was admitted for 45 days. So these were the different investigations. All investigations for all different. So these were the general physical examination, systemic examination. So I'm not going in details, but patient also had extramedullary right more than left involvement with torticollis, and patient towards the end developed some anemia. TLC was more or less correct. So you must have gone through this investigation, did not reveal much abnormalities, right? Urine culture showed Klebsiella, long hospital stay catheterization. So this could be because of that. I don't think this was relevant here. There is one report of low CD4 count, but when it was repeated, it was fine. He also had serum cryptococcal antigen positive, but all other investigations for other infections were negative, right? Because the patient had this ring-enhancing lesions, so obviously TB was another differential diagnosis, so nothing came out. CSF analysis was done again. See, again, it is antigen is coming positive, but cryptococcal fungal smear culture are again negative. Right. MRI was done. So again, much worsening of those lesions, and now it is coming to the periventricular region from this just occipital cortex. So this is how it is. Spinal cord was more or less okay. Right. So any possibility now, or you are still okay with cryptococcal meningitis doing everything, or there is some alternate diagnosis? Okay, so someone, yeah, very nice, vasculitis, fantastic. So it can be a vasculitis, CNS vasculitis, or any other vascular disorder of the CNS, which can be because of this. Now, think one thing. This patient is given adequate antifungals, but the cryptococcal but the patient's symptoms are not improving. That is number one. And number two, repeatedly, cryptococcal antigen in CSF is positive, but culture and fungal smears are negative. Does it give you any indication, any other information? So what could be the possibilities? Why the patient is not responding? Cross reactivity, but the patient was once reported as in the CSF cryptococcus was seen, and I did not reveal you, but the lung biopsy which was done also showed presence of Cryptococcus in lung. So I don't think we can go away from a diagnosis of cryptococcal meningitis or disseminated cryptococcosis in this case, but the patient is not responding. Why? What could be the possibilities? So if this is a TB and the patient is giving sufficient ATT and the patient is not responding, what do you think there? What comes in your mind?
Drug
Sorry?
resistance.
Resistance, very important, very important. Resistance. So resistance to drugs, right, which is much more common with your in bacteria, but can also occur with fungal diseases, right? But here patient was given multiple types of antifungals, so it can be one thing. But if the patient has resistance, right, then the fungus should not disappear from CSF. It is not even now culturable. So is there any other possibility you can think of?
Immunocompromised.
Immunocompromised, but there is no obvious immunocompromised state as of now. Patient was not positive, HIV was negative, other PID workup was negative, primary immunodeficiency workup was negative, CD4 counts are in normal limits. Patient did not have SCID and other things, CVID. Anything else? So now that you come to the possibility of immunological deterioration. So that can occur with many other infections, especially TB and all. Right. So this is called altered immune response or iris kind of a presentation. Right. Ah, yes. Right. And remember one thing, CSF, this cryptococcal antigen can remain positive for up to 12 months once the patient gets infection. So that does not give you a thing that is active infection. So now drug-resistant cryptococcal and cryptococcal iris. So these two possibilities were kept. So what is iris?
Immune reconstitution
Immune reconstitution,
syndrome.
inflammatory syndrome.
So this is more
Inflammatory syndrome.
right. So this is more common with in setting of HIV, remember, but can be seen in non-HIV setting also. So patient was added. So steroid was started. So immune. So steroids. So anti-inflammatory drugs. So and because of the increased shunt, neurosurgery consultation was taken, but it could not be done. Then thalidomide was also added because that is also a drug which helps in controlling the iris, right? So patient had some drop in hemoglobin. Now patient started having persistent diarrhea, so which was not responding to conventional antibiotics. So stool examination did not reveal any significant pathogen. So this was the CT enterography. You can see there is slight thickening of the wall of this bubble, but there is as such no obstruction or any mass. Colonoscopy was done, which showed complete loss of vascular pattern with multiple aphthous ulcer, hyperemia, which was involving a large areas of the, especially the large intestine. So colonoscopy biopsy was done, which showed there is some ulcer, which was not very specific. Right. So it could be an infectious diarrhea because of the cryptococcus, or could be because of some drug, especially flucytosine is known for causing diarrhea. So it was withheld. So patient did not respond well. He had sudden onset of hypotension, developed metabolic acidosis. He started with inotrop, could not be revived, and he was a complete autopsy was performed. Right. So this was the course of this patient. So we have discussed the possibilities It could be a cryptococcal meningitis. It could be some superadded in second infection or a malignancy. We cannot exclude it completely. Second, so that is a basic disease. Second important question is why the disease persisted. The cryptococcus was treated adequately. Why did it persist? Was there a drug resistant or there is some iris kind of a presentation? Number 3, why this diarrhea developed? Number 4, did the patient have any immunocompromised pattern of uh, insult for which he was not responding? So with this, I will stop presenting this particular PPT, and if you want, you can discuss. So, anyone wants to ask any particular question or any other bright ideas? Okay, I think we can now move to your pathology PPT, right? Here I am. Hi, is my
Yes, sir.
screen visible?
Yes, sir. Yes, sir.
Right, just give me a second. Right, so this is the case. So whenever you, if you get a chance to perform autopsy in your life, so there are certain things we need to take. First, read the clinical history carefully because you have the entire body in front of you. If you don't read the clinical history and their particular questions, then you can't take adequate samples from different organs, right? And nowadays with autopsy, there are so much advancement of molecular studies, so you need to take particular samples from different areas as per the merit of the case. So you have to also do a external examination and look, you have to see the serous cavities. So in this case, patient was moderately built and serous cavities like pleural, peritoneal and pericardial cavities were within normal limits, so there was no effusion. This is the antemortem lung biopsy. Yes, now so it's all your fields, all are experts, huh? Now who will tell? So Sneha, are you
Yes, sir.
there?
Yes, sir. Yes, sir.
What do you see? Is it normal lung parenchyma or abnormal?
No, abnormal.
Why abnormal? Normally, what should you see?
The alveoli will see more like white appearance. Like the alveoli will be properly seen. Here, there's something between the alveoli or the alveoli filled with something.
Yeah, so it's more of a solid kind of appearance, right?
Yeah.
So you can't see this alveolated lung parenchyma. And here you can see there are some pink areas, some pale areas, right? You can see these
Hmm.
pale areas.
Hmm.
Fine. So we will describe this field. Before, can you see here? What are these spaces? Some clear
Alveolar
spaces.
spaces.
These are, I think these are too small for alveolar spaces. These are some material I can say. Let me go to high power. You can see these are the alveolar spaces are filled with something. There are interstitial areas are also showing some inflammation. But within the alveolar spaces, can you see? There is some mucoid kind of some material and within which there are some structures. Can you appreciate those
It is
structures?
giving alveolar soap bubble appearance.
Fantastic. Kind of a soap
Cryptococcus
bubble
will
kind of
give.
appearance.
Yeah.
So this is high power. So this kind of some structures here of some variable dimensions. Some are small, some are large. What is this picture? Can someone describe, Nivedita?
Sir, it is like some organism as
So let me tell you, this is
polarized kind.
polarized microscopy, right? So what kind of structure are these? Some, you can see there's a cross kind of a thing.
Yes,
Can
sir.
you appreciate? So
Yes,
this
sir.
is
Yes.
called
Yes, sir.
Maltese cross appearance.
Maltese.
Right? So this is called Maltese cross appearance. Okay. So if we see such a structure in alveolar spaces, what are the differential diagnosis that comes into your mind? Forget about the history of Cryptococcus. Keep an open mind and tell. What are the differential diagnoses?
Babesiosis can be.
Sorry?
Babesia
Babesiosis.
microteam.
Anything else? Now you are talking about this organism. We are sure these are organisms. So what are organisms may look like this kind of a berry-like appearance, a soap bubble-like appearance. Cryptococcus?
Cryptococcus.
Anything else? Any other fungal infection? If I say this is a renal, uh, sorry, transplant patient, post-transplant patient, anything, any particular infection that comes to your mind?
Cytomegalovirus will be.
No, cytomegalovirus does not have this kind of a bunch-like appearance in a space. It involves particular cell, right? So the differential diagnosis here would be your Cryptococcus, histoplasma, those things, right? So what stain is this? You can see two colors. One is pink, one is blue.
AB pass.
Fantastic. So PS Alcian blue. So which stain is done first, Alcian blue or PS? When you do PS Alcian blue.
So first Elsham blue.
Fantastic. First we do Alcian blue. Otherwise, if you do PS, everything will be PS positive. There is no scope that Alcian blue can be stained. Now, can you please also interpret, Chaitali?
Yes, sir.
What is happening?
So the
So you see,
organism is stained. The capsule of organism is stained by Elsham blue.
yes. So you see, towards the periphery it is positive, right? So it has a mucopolysaccharide capsule. That is number one. Number two, what is happening to this particular structure? So these are called narrow neck budding. You see, there is one organism from which it is, second one is budding, right? So one is giving rise to another with a very narrow neck, like here, like here. Oh, can you see my cursor, or should I change to this thing, laser pointer type? Let me try laser pointer. I think that will be better. You see this kind of narrow neck budding here? That is number second thing. Because when you have the differential diagnosis, you have to have particular points in mind. Number three, size of the organism. See, look at this particular one and this particular one. Do they look similar or they are different in size?
Different in
Different
size.
in
Markedly different, hai? So some are small, some are large, some are very large, right? So their size ranges from 5 to 20, almost 25 micron. So these are the important points when you try to differentiate a histoplasma from a cryptococcus. So this conforms to the morphology of
Cryptococcus.
cryptococcus,
Cryptococcus.
right? So this is cryptococcus. Narrow neck budding, huge variability in size, and a mucopolysaccharide capsule, right? And this kind of background, which is a gelatinous kind of a thing. So that was antemortem lung biopsy where we diagnosed cryptococcus. Now this is postmortem lung This is the pleura. This is the tracheobronchial tree. The lung was subclipitant. There is not much solid thing. Some areas you could see there is a lot of neutrophils. Again, the alveolar spaces are filled. But here, the nature of the inflammation is different. Previously, we saw mostly macrophages. Here we are seeing mostly neutrophils, right? There are some bacterial colonies. And what is this kind of a structure? Some organized kind of a structure. So these are
Cryptococcoma, maybe.
no. Cryptococcoma is a mass.
Mass.
Right. Cryptococcoma is a mass. Aspergilloma is a mass. Right. This is a structure which is there in the alveolar space. These are the alveolar spaces. So this is a vegetable matter. Right. You are seeing some bacterial colonies, some macrophages, some neutrophils, some vegetable matter. Again, this is the next photograph, some other alveolar space. Lot of squames. You can see this kind of squames, vegetable matter, fibrin, bacteria. So what is your diagnosis if you see this kind of there is no cryptococcus. So if you see squames, if you see vegetable matter in lung, what do you think is happening to this lung? Where are they coming from?
Aspiration.
Fantastic, aspiration. So this is terminal aspiration, and that is causing this pneumonia, because when there is
Pneumonia.
esophageal contents that come back to your lung by aspiration, you see all these things: vegetable matter, squames, fibrin, and bacterial colonies. But at postmortem, there was no cryptococcus. So, was cryptococcus a misdiagnosis or something else happened? No, so you have to see here, this is a typical mycobacteria does not produce this kind of a reaction. This is only limited to your air spaces, right? So this is aspiration, and you see ZNPS, GMS, they are negative, and these are positive for gram. So gram positive cocci you can see here, and there are also some gram negative cocci, right? These are appearing red. So mixed kind of infection, which is because of aspiration. No cryptococcus. So was it a wrong diagnosis or it happened? Another possibility could be the lung lesions and may have responded to a treatment. Coming to brain. Is it normal weight?
Yes.
Yeah, I think it is
It-
normal for the
Yes,
age
sir.
group. Okay, there is some atrophy you can see here. There is some atrophy, this widening of this sulci. There is as such no exudate, either on the convexity or at the base of the brain. Okay. Again, on the lateral aspect, there is no. This is the spinal cord. Again, as such no exudate here. So these are the slices. This is in which plane? This is called coronal plane. Right? Any plane that divides up any organ in anterior and posterior is coronal plane. Okay. Cookie, what do you see in these coronal sections of the brain? Any abnormality or this is normal? Anyone wants to try?
So dilated ventricles.
Fantastic. Dilated ventricles. What does it mean?
Obstruction.
Obstruction to the PSF.
Hydrocephalus. Hydrocephalus can be obstructive, can be non-obstructive, right? There are two types of hydrocephalus. So unless we see obstruction, you should not call it obstructive obstruction. We just should leave it hydrocephalus. Now, is it unilateral or bilateral?
Unilateral.
It is bilateral, but however, right side is more than left, right? Bilateral with one side is more dilated, but in both sides you can see this angle of the ventricles are quite rounded, right? And its occipital cortex, this temporal lobe, you can see this is quite atrophic. So 72 years male, almost 5-6 months of neurological illness, you can expect a lot of atrophy. So that is fine. Now coming posteriorly. So this is which lobe? Any idea? Posteriorly, all discussed occipital lobe, right?
Occipital lobe.
Okay.
Now, can you see any lesion here? Any lesion? Before,
Yes, sir.
where are the lesions? So you can see this cortex versus this cortex. This is much discolored, है ना?
Yes, sir.
Granular, thinned out cortex. So this area, this area, this area, this is almost like a breaking down, है ना? But if you see, these are almost restricted along the cortex. It is not going into underlying white matter. You know, this is gray matter, this is white matter. Gray matter, white matter. Gray matter is gray, white matter is white. Here, gray matter looks more yellowish, not much gray. Here. But white matter appears fine. So bilateral, as exactly what we saw on radiology, it is like that, and here it is like almost like a ring, right? This is like a ring. This is like a ring. Can you appreciate? So multiple ring-like lesions, which peripheral areas are kind of necrotic. Brainstem also has small necrotic lesions in the midbrain as well as in the cerebellum. Multiple areas we have necrotic infarct-like lesions. So this is your low power photomicrograph from the brain. So this is the brain parenchyma here, underlying. This is the leptomeninges. You see, this is the leptomeninges. And what are these structures? These are meningeal arteries, right? Okay. Any abnormality here? Is it normal or this is abnormal? So this leptomeninges you can see here is
Inflamed
very wide.
or something.
Normally, if you study any section from brain, you can't see leptomeninges, right? So arachnoid and pia matters are very closely rapport to each other, right? So that cannot be visible just on light microscope normally. But here you see, this is wide, very, very wide. So something is happening here. And underlying brain parenchyma you can see is very pale. I will come to these areas. So this is that photograph. You can see this is a lot of cells, lot of inflammation in the leptomeninges. What structure is this? Again, I will come. I'm asking. This
Meningeal.
is
Meningeal artery.
fantastic. This is the meningeal artery, right? So meningeal artery again, and this is the underlying brain parenchyma. So I don't know how many of you have the opportunity to see normal cortex, but I can tell you this, compared to normal cortex, this is markedly pale. It's not normal. So this is your leptomeninges. You can see what are these cells? These small cells are lymphocytes. And there are some large cells. And there are some areas of necrosis here, right? Okay, now come here. What are these?
Macrophage.
Fantastic. So
Macrophages.
these are macrophages, right? And
Ingested something.
they have engulfed something, they have injected something. Again, kind of a raspberry kind of appearance, mulberry
Yeah.
kind of appearance, which is typically described in which organism? This kind of a,
Cryptococcus.
no, histoplasma.
Oh, sorry,
This is typically described in histoplasma.
histoplasma.
Yes, but you see again here when we perform this special stain, they have polysaccharide
Narrow
capsule, they have narrow neck budding, right? And there is variation in their size, right? Some are
Yes.
large, some are small. So again, this is Cryptococcus only, which is sometimes resemble your histoplasma. You can see this
Histoplasma.
nice narrow neck budding here, right? So this is only Alcian blue. This is not PS with Alcian blue. Okay, so now we have no doubt that there is cryptococcus here, na? So in brain we have cryptococcus, but if you see a case of florid cryptococcal meningitis, you see a lot of cryptococcus floating in the leptomeninges. But here most of the cryptococcus are within these macrophages. So that is abnormal reaction. Now this is your underlying cortex. So to show you that this is the normal color of the cortex, pink. Can you see?
Mm.
Ah. But this area is pale.
Mm.
This area is pale. So these are areas of infarcts.
In fact.
Right, this is the hyper of the same. You can see a lot of vascular proliferation and there are a lot of cells. What are these cells? Any idea? I'll show high power. So where do I have a high power? Yeah. So this is the high power, the same. What are these cells which abundant this kind of cytoplasm?
Jitter cell.
Slightly vacuolated. Sorry?
Jitter cell. Jitter
No,
cells
these are
in an impact.
macrophages. These are
Macrophage, yeah.
macrophages. So this is what I see. This is CD68. Right, so this is highlighting all these macrophages here, right? Glial cells are basically hypertrophic astrocytes. Let's see whether they are there or not. Okay, so now these are the meningeal arteries. What is happening to these meningeal arteries? Are they normal or abnormal? Is their lumen normal? Abnormal, right? So what is abnormality? So this is your, so if you think the structure of arteries, what are the layers from outside to inside?
Tunica, internal,
And
media, and external.
Okay, so
Mm.
so but you are nearly correct, but not totally correct. So the correct terminologies will be tunica, intima, media, and
Intima. External.
adventitia, right?
Mm.
Adventitia, media, intima.
maintain.
In between intima and media, you have a thick pink line. What line is this?
Elastic lamina.
Which
Uh,
elastic lamina?
internal.
Internal elastic lamina,
Elastic lamina.
right? So ideally, just inside this internal elastic lamina, there should be endothelial cell, and then the
Mm.
entire thing should be lumen. What is happening here? There is a lot of intimal proliferation here, and the lumen is very narrow. Can you see? Here also, the lumen is extremely narrow. What stain is this?
EVG.
EVG. What does it show? So this is the media which has elastic tissue. This is the interelastic lamina which is very thick, blackish, and this is the intima which is proliferating, and the lumen is maybe 10% of the original lumen. So multiple sections from this meningeal arteries over this lesion showed this kind of vascular changes, right? So there is, what is this called? And adjacent to it, you have this inflammation, macrophages containing cryptococcus. So this is
Vasculitis.
vasculitis, secondary vasculitis, right?
Secondary
This is not a
vasculitis.
primary vasculitis because you are seeing in the milieu of only in the infection region. When you examine the tissue sections from other areas where there is no cryptococcal meningitis, then it is, those vessels were
Normal.
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 Right? So if it's a primary vasculitis, irrespective of the infection, we'll have to see these vascular changes. But here we are seeing only in the area where there is infection. So this is a secondary vasculitis. Okay. Now this infection is also involving these ventricles. You can see this is the ependymal lining and this necrosis, macrophage, right? Some inflammation, just at brain parenchyma. So again, it was involved. So a lot of macrophages here, all containing this cryptococcus, right?
Mm-hmm.
What structure is this? This place which
Parenteral
is the
reaction.
ventricles.
Mm.
Some papillary structure, lot of vessel inside. Any idea? Any plexus?
Choroid plexus.
Choroid plexus.
Fantastic, fantastic. So this is choroid plexus. So choroid plexus was also involved. So a lot of ventricular involvement, right? So remember this lot of hydrocephalus. So if all the ventricles are kind of showing this much inflammation, so there will be a lot of extra CSF production of the inflammation. So that is one reason. There was a small lesion here, which was a healed cryptococcoma in the frontal cortex. So this was a healed thing, right? So in brain we had cryptococcal meningitis, which was treated, and now we have meningovasculitis with infarcts. There is ventriculitis, there is choroid plexitis, and there is hyalinized cryptococcoma, and there is a yeast form of cryptococcus, which are almost restricted to macrophages. So this kind of vascular involvement is a very typically seen in your immune reconstitution syndrome, right? So iris, cryptococcal iris can present with this kind of thing. Okay, now let's move to other organs quickly. So liver, this is the liver, this is the spleen, and what organ is this?
Pancreas.
Pancreas. What is this?
Gallbladder.
Gallbladder.
Gallbladder. Very good. So liver weight normal 14-20 gram, but a close inspection, if you see the surface, is it normal
Nodule.
or abnormal?
Abnormal.
Abnormal.
Abnormal, right? What are you seeing here?
Nodule.
Nodules.
Micro.
Nodules. So some are small, some are little large, right? But mostly small. So this is the histology of liver. What do you see? Is it normal? Is the
No.
lobular architecture maintained?
Yeah.
It is not, right? You can see
Not.
there are these thick septa here,
Septum.
connecting this portal tracts to portal tracts, and also some central veins, right? So there are bridging septa, portal as well as portocentrals, right? Portocentral bridging fibrosis with some this kind of nodule formation, right? So this is called. So this is what stain?
Retic.
Retic.
Retic. What color reticulin stain gives? What is reticulin stain? What is
Used for
reticulin stain?
Black color it will be.
So reticulin stain is basically a silver stain. So
Yes, sir.
the reaction, it gets silver get deposited. So if silver gets deposited, what color would it give? The
Black.
reticulin fiber.
Black color.
Fantastic. Black. Is it black? No. Right.
No, sir. This is Mason's trichome.
Fantastic. So you have trichrome stain, hai? So what is this mesentrichrome showing you? That there are this again bridging fibrosis
Bridging fat.
and giving rise to nodules, right? So there is a cirrhosis.
Yes.
So again, the high power, what are you seeing here? This kind of vacuoles here. What are these?
Steatohepatitis.
Steatosis. There is no hepatitis here at this moment. There is no inflammation, but there is mostly macrovesicular steatosis. Right. So again here you can see this macrovesicular steatosis, mild only portal tract inflammation, not much. Right. So if you see this kind of a cirrhosis, macrovesicular steatosis, and some fat, what would be the cause of cirrhosis in this patient?
Patient
He's
had
an
history of
alcoholic.
alcohol intake.
Fantastic. Long history of alcoholism. So that can give you this cirrhosis, and that is almost in a cirrhotic dose. And remember one thing, alcoholic patients are more prone to develop cryptococcal infection. So that is a known risk factor. Spleen, this is spleen, which is showing normal red and white pulp. Pancreas, is it normal, abnormal? Can you see the
Normal.
normal, right? So you can see the acina, you can see the islets. You can make out this islet, right? So it is normal. This is the heart, which is opened by modified inflow outflow technique. The various chambers, valves were normal, microscopically also, heart was normal. Now coming to kidneys, weight 320 grams, which is again normal for this age. This is the aorta. You can see a lot of complicated atherosclerosis here. You can see there is some atheromatous plaque. Renal arteries were, however, patent. Kidneys are of normal size. There is no scarring, anything. So on histology, you can see what are these? This is PF10, right? So what are these?
Glomerulus.
Glomerulus.
And these two?
Or normal glomerulus.
And what these two?
Scleros.
Glomerulus. So 72 years male, there is some atherosclerosis. You can expect some glomerular sclerosis, so normal. But otherwise, in other glomeruli, they were normal. There was not much glomerular involvement. There is some tubular atrophy here, you can see. And again, in these blood vessels, you can see some interval proliferation. So there's long-standing hypertension. Okay. Now, this is the antemortem colonic biopsy, right? You can see this colonic biopsy. So is it normal or abnormal? What is the main abnormality? So you have to go through a lot of systems in a CPC, all organs you have to examine and see what are the abnormalities. Remember, this patient had diarrhea.
Partially ulcerated.
Ulcerated and
Atlases.
you see, normal
Atlases.
colonic biopsy should be studied with crypts. Here there is marked loss of these crypts. Crypts are lost and there is some dilated crypts in some areas. So this is the high power. What are you seeing here? Again, these areas, there's loss of crypts, right? You can see some cells and there is significant mucodepletion. What is mucodepletion? What is mucodepletion in a colonic biopsy? So loss of goblet cells, right? So there is not no goblet cell in this biopsy, but normally you should have a lot of goblet cells, right? So they are not there. Number 3, what is happening here? Can you see these nuclei? They appear little enlarged, they appear little hyperchromatic. What is happening? Is it dysplasia?
Hyperactive ATP.
Very good. So this is reactive atypia because of inflammation or a regenerative atypia. Fantastic. Now what is happening to these crypts? What is the structure? What is the structure? So these are normal epithelial cells here. These are normal epithelial cells here. But this has a very pycnotic nuclei, right? Small, dark nuclei and very pink cytoplasm. So what is this happening? Apoptosis, yeah. So Dr. Mandip has said this is apoptotic, absolutely. So these are apoptotic epithelial cells, right? So a lot of apoptotic activities were visible in this, right? Again, you have a lot of apoptotic activities here, some regenerative atypia. So now what do you want to look for very carefully? If you have this kind of a picture with loss of crypt, regenerative atypia, apoptosis, first thing what comes to your mind? This is practical, I'm saying. If you in a practice, if you practice GI pathology or routine pathology, you will get this biopsies with history of diarrhea and they will ask you what is happening. So first thing that comes to your mind with this kind of a biopsy is viral infection. Right? So you have to look for viral inclusions. Most important virus which can produce this kind of CMV. Fantastic. CMV. You must look for it. If you don't look for it, you will miss it. These are things if you have to keep your mind open. So we did not find it, and these were the ILCs we did, CMV and adenovirus, they were negative, right? So now coming to the post-mortem examination, this is the esophagus, stomach, which are grossly fine, unremarkable. This is a small intestine which was almost fine, but look at the large intestine. So these are the normal folds. Here what is happening, these areas, the mucosa is completely granular, there is no fold. Folds are absent. But if you see, these are all superficial ulcers, not deep ulcers, right? Or not fissuring ulcers. Okay? Again, in large intestine, you can see this is very granular mucosa. Yeah. These areas you can see the normal folds, but these areas they are all gone. This is flattened. So what can come to your mind looking at this gross picture? Can this be ulcerative colitis?
No,
No,
they
ulcerative
will
colitis
be
usually should not look like this. Huh? You should see
cobble,
pseudopolyps, cobblestone, all those
pseudopolyps,
things. Right.
cobblestone.
Right. So this is the low power picture. So what is the pathology? Is it in the mucosa, the submucosa, or transmural? So it is mucosal.
Edema,
Mucosal.
Mucosal.
Very restricted, right?
mucosal.
So there is diffuse ulceration. You can see loss of crypts. So in this entire patch, there is no crypt. There is dilated crypt. The similar things that we saw in our biopsy. Similarly, here there are thinned out crypts. There are a lot of apoptotic cells here, right? Regenerative ATPR. Don't think this is low-grade dysplasia, right? Seen in the entire context. Again, similar changes here. So if we see this kind of pathology, what all comes to your mind? Now you have the autopsy in front of you. This is not just not a biopsy. So another important possibility here is ischemic colitis, right? If there is a long-standing ischemia, you can have this kind of a picture. But in ischemic colitis, you should also expect some submucosal fibrosis and fat infiltration, which is not present in this case, right? So we examined these mesenteric vessels, but they were of normal caliber, normal size, no occlusion, nothing. So this is basically an apoptotic colopathy. Right. So these are the common causes. GVHD, drug, viral infections, CVID. Right. So can this be GVHD? Was there any history of any grafting? No. There was
No.
no history of any transplant, so GVHD is out. CVID workup was done. This patient did not have any CVID. Already discussed during clinical presentation. Viral CMV and adenovirus are common causes, but we have excluded those. Huh? We have done ICE, we have done PCR, nothing. So now we are left with
Drugs.
drugs, right? So as I mentioned you, this patient was given flu cytosine.
Blue cytosine.
Flu cytosine can produce exactly this kind of apoptotic colopathy, right? So these are the pictures from a previous publication, right? So we can attribute this diarrhea because of flu cytosine induced apoptotic colopathy. Bone marrow, thyroid were within normal limits. So coming to the final autopsy diagnosis in this 72 years male who was had a disseminated cryptococcosis. I'm saying disseminated because patient had previous lung infection and CNS infection, but lung was adequately treated. CNS, number one, drug penetration is not so good. Number two, patient has immunological complications in form of iris. So cryptococcal meningitis with brain infarct, which was related to this iris. Patient has aspiration pneumonia, which is obviously a terminal event. Macronodular cirrhosis, which is alcohol related. There was some pancreatitis, I think I missed that, and drug-induced apoptotic colopathy. Right? So now can you neat up the entire story? Is there
So
a clinical
what did adrenals say? They were adrenal
adrenals were normal,
enlargement.
right? Good, very good questions. Adrenals were normal. So I think what has happened in this case, whatever antifungal the patient received, that cured the disease from the systemic things, right? In CNS, the disease kept on progressing. That must be secondary to your, thanks to your immunological complications. So Lower immunity is also dangerous. Excess immunity is also dangerous. So this is exaggerated abnormal immune response, which is causing lot of meningeal fibrosis, meningeal inflammation. Normal cryptococcal meningitis does not produce much meningeal inflammation, right? It is mostly a gelatinous material or in which the cryptococcus keeps floating. Here we saw a lot of fibrosis, lot of lymphocytes, lot of macrophages containing this cryptococcus there. And number two, the drug penetration in CNS is also not that good. So that is the reason possibly this patient kept on deteriorating in your neurological symptoms. But we did not have any evidence of cryptococcus in post-mortem, either in lung or in adrenal. So I think I can stop the presentation here and we can
Yes, sir.
discuss what happened finally. So yes, I think so this is how CPC is usually done, you know. First clinical presentation, then pathological presentation, and then the dissection of the case. Why did this happen? Why did this not happen? So whatever you have discussed so far is absolutely fine. This is how things go. And this apoptotic colopathy was also very nicely correlating with the history of drugs, especially this 2-cytosine, which is known to cause apoptotic colopathy. So, you know, there are various mechanisms how drug can produce GI-related symptoms, right? And apoptotic colopathy is one of them. So if you read the drug-induced gastroenteritis or GI insult, there are a few mechanisms that have been described, and apoptotic colopathy is one of them. So there are certain drugs which can produce certain pattern of your tissue injury. So I hope now you got to identify the various the sides of the brain and how to differentiate cryptococcus from histoplasma. So some basics, though, I think you must it's got clear, right? So if you have any questions, you please can ask, or if you have any comments.
Chat box, I'm seeing a lot of comments, sir, but no specific question.
Okay.
Students, if you have any doubts or any question.
Right. So you have said ki CMV inclusions you should see. Where do you look for CMV inclusions in colon? In which cells you look for CMV inclusions?
Endothelial cell.
Fantastic. So it's not primarily the epithelial cells, it's the endothelial cells and fibroblasts, stromal cells. And adenoviral inclusions, in which cells they mostly involve? They are the epithelial cells. Okay. Right. Sir, are you there? Sumit sir or sir is, I think sir has left. Huh?
Yes, sir. Don't
I
think
think
it's
sir has
there.
left. So if you
Very
have
good
any,
talk now.
Yes, sir.